Good morning. My name is Nico Moshe, and together with Ala Gecht, Ala, can you show the video? We are the co-chairs of this session that is very dear to our hearts, dealing with a personal and global perspective of epilepsy, trying to address the issues not only from the person's perspective, but as well as what we can do as a society, a medical society and a civil society to improve the care of people with epilepsy. This is one of the major goals that the NAEC has had over the years together with the IBE. It brings us together and it's important as we go forward to change some of the misconceptions and improve the care that we provide to our people. And it is our people. In this presentation, we also initially included a person to tell us a little bit about epilepsy and how it felt. The title of the talk was How My Life Changed in 35 Seconds, which is often what happens when somebody experiences the first seizure and the consequences after that, which is taking medications as well as the social issues, motility issues that we're going to hear of from all our panelists. In this presentation, the topics have been pre-recorded and each one is about 12 to 13 minutes long. So we will have ample time for discussion between you that are participating, and I see that there are about 80 participants, which is wonderful. We need even more because this is one of the most important aspects of epilepsy. Without any further ado, we'll have the first presentation, which will be done by Dr. Nathalie Jeté, who is now at the Mount Sinai School of Medicine, and she is the chair of the North American Commission with a long-term commitment on issues related to patient advocacy. Nathalie, are you ready?
Yes.
Okay.
Good morning, everyone. It's my pleasure to join you for this first ILE North American Regional Congress. I'd like to thank the Scientific Committee, as well as our chairs, Professor Moshe and Gut, for giving me the opportunity to speak to you today about the global burden of epilepsy. I don't have any relevant disclosure, but I'd like to apologize in advance if I don't cite your important and relevant studies, as there are hundreds of studies addressing the burden of epilepsy. And in the interest of time, I also will not discuss the burden that is attributable to epilepsy comorbidity, but we know that this is considerable. I'm going to briefly introduce the report that was just published last fall on epilepsy, a public health imperative. I'm going to provide some definitions and then address some factors that can affect epidemiological estimates. I'm going to focus on incidence and prevalence of epilepsy, disability-adjusted life year or DALY, mortality and economic burden, and finish with some concluding remarks. The report that was published last fall highlighted the urgent need to make epilepsy a public health priority. It's a collaboration between the World Health Organization, the International League Against Epilepsy, and the International Bureau for Epilepsy. And it also addresses how further action is needed to address the global burden of epilepsy and its impact on those living with epilepsy. The report showed that the burden of epilepsy is high, that those with epilepsy continue to be the target of discrimination even in this day and age. And it also showed that there's a lack of universal health coverage globally, particularly in low-income countries where, up to 90% of people in some regions don't have access to anti-seizure medication or access to healthcare. However, we know that even in high-income countries, such as in the US, for example, access to healthcare can be a considerable issue. And the report also shows that 1 in 4 cases of epilepsy are preventable. The report also provides a really nice timeline of the various important initiatives over the years aimed at reducing the global burden of epilepsy, starting more than 20 years ago, back in 1997, when the Global Campaign Against Epilepsy was launched, and goes over the timeline of very important initiatives and reports that were published up until this date. So we know that more than 50 million people globally are affected by epilepsy, and that nearly 80% of them live in low middle income countries. The reason we think the rates are higher in low middle income countries are in part due to endemic infection, higher incidence of injuries, and a lack of access to healthcare. The burden is substantial globally, and I'm going to focus on some of these estimates shortly. But first, before proceeding to a discussion of the global burden of epilepsy, I want to go over a few definitions. So I'm going to talk about lifetime prevalence during the talk, and that's the risk of having epilepsy at some point during the lifetime. It's used to estimate the cumulative incidence of epilepsy. I'm going to also refer to the point prevalence, which is the number of cases of active epilepsy divided by the target population on that day, usually per 1,000 persons. And I'm going to discuss mortality and refer to the standardized mortality ratio, which is the ratio of the observed deaths to the expected deaths in the target population. There are many factors that can influence estimates of epilepsy burden. We have to keep those in mind when we read studies to see whether epilepsy may be under ascertained or if any cases could be misclassified. So the consequences of the condition. So some etiologies of epilepsy can be associated with higher mortality, such as severe traumatic brain injury. There can be individual and community-based differences, such as sociocultural factors and stigma that may influence the ascertainment of epilepsy. There may be, people may conceal their diagnosis, for example. Limited availability of diagnostic tool and access to anti-seizure medicines may result in, again, an under-ascertainment of epilepsy. And then there are challenges with ascertainment. So there can be diagnostic misclassification, there can be recall bias, and so on. So all these things have to be considered when we review studies about the burden of epilepsy. Starting with the incidence of epilepsy, these are data from a systematic review, and these include the number of studies that could be included in these pooled estimates. And so we estimate that the incidence rate of epilepsy is around 61 per 100,000 person years, and that the incidence is higher in low and middle income countries. You can see at 138 with a very broad range, and in high income country 48.86. We also know that incidence of epilepsy is higher in lower socioeconomic classes. The incidence of epilepsy has also been examined by age and sex. And though there's a slight difference between men and women, it's thought to be mostly explained in part due to a concealment of the condition in women for sociocultural reasons. There are studies in India, for example, where women conceal their diagnosis because they may be considered unmarriageable if they don't. In general, though, the differences between men and women are not statistically significant. There is a highest incidence in the first year of life and then later in life. And in low middle income countries, the incidence actually peaks in children, and that's thought to possibly be the result of an under-ascertainment in older individuals, as well as demographic structure of these countries that are very different than in high income countries. And we also know that the incidence is increasing in older adults with epilepsy, in part due to increased life expectancy, but also with a simultaneous increase in conditions associated with epilepsies in that age group, namely stroke, tumors, and neurodegenerative condition. This is a classic study published by Professor Hauser and colleague, looking at the incidence of epilepsy in Rochester, Minnesota. And you can see that in the first year of life, the incidence is around 86 per 100,000. Then it decreases in the middle age to 23 to 31, and in older adults up to 180 per 100,000 per year. The prevalence of epilepsy has been studied in numerous studies, hundreds of studies, and the point prevalence is estimated at 6.38 per 1,000, so just under 1%. The lifetime prevalence is 7.6 per 1,000, and again, similarly to incidence, the prevalence is higher in low and middle income countries. The 2016 global burden of disease analysis estimated that there were around 50 million people living with epilepsy, and that 24 million of those had active epilepsy of genetic or unknown etiology. And the prevalence was similar in men and women, actually, when you looked at all these studies, even though here in sort of orange, reddish color are male, and in the blue color are female. It looks like it's lower, but it was not statistically, this difference was not statistically significant. You can see a higher prevalence peaking in the early years of life, and then the prevalence increases over time. There are limited data that at the population-based level that address the incidence and prevalence by seizure and epilepsy type. Unfortunately, generally in high-income countries, focal seizures tend to be the predominant type, but in low-middle-income country, generalized tonic-clonic seizures are the predominant type, and that's mostly thought to be due to an under-ascertainment of other seizure type and due to a lack of recognition and a diagnostic tool that limit the ability to differentiate focal from generalized seizures. Disability-adjusted life years is another common estimate of the burden of epilepsy that we study. And in 2016, it actually accounted for more than 13 million daily, actually, and epilepsy accounted for 0.5% of the total disease burden, which is really, really significant. In children and young adults, epilepsy is the greatest burden compared to any other neurological conditions. And when in the global burden disease analysis, when they age standardize daily rates for all neurological disorders, epilepsy ranks second to eighth of all the neurological conditions, depending on the region that they were studied in. Important causes of mortality in epilepsy include sudden unexpected death in epilepsy, status epilepticus, unintentional injuries, and suicide. There are others, of course, but these are important ones that are prominent. We know that premature mortality is higher in people with epilepsy. And in high-income country, the standardized mortality ratio is actually 2.3, and even higher in low-middle-income country at 2.6. The incidence of epilepsy is about 1.1 in younger patients to 1.3 and higher in older patients. And it's pretty consistently risk factors for SUDEP have been identified as being generalized tonic-clonic seizure, bilateral convulsive seizure, nocturnal seizure, and a lack of seizure freedom. Very important to address those with the aim of reducing SUDEP. These are data about mortality and epilepsy from two very elegant systematic reviews that have been published, one in high-income countries and one in low-income countries. And the first looks at the standardized mortality ratio based on years since diagnosis. And what you can see is that standardized mortality ratios are certainly higher earlier in the diagnosis of epilepsy and then sort of decrease and then may perhaps increase again later in life. In this diagram here, it's looking at standardized mortality ratio and age in years, age of epilepsy diagnosis. And what you can see is that it is higher again in early life. The economic burden of epilepsy has been evaluated in many studies, and although we know that there's a high cost burden of epilepsy, it's well recognized. It's been poorly quantified around the globe, especially in low-middle income countries. This is shown here where you can see that there's enormous variations in the estimates of cost per capita. So there's an urgent need for studies that evaluate the direct and indirect costs of epilepsy in a standardized and systematic way at the country, regional, and global level. And you can see that most of the regions are high-income countries. So in conclusion, epilepsy accounts for 0.5% of the total disease burden. The burden is high globally, but even higher in low socioeconomic status population and low and middle income countries. We know that children and older people are particularly vulnerable, and we know that we expect the burden to increase, especially because of the aging population. And there's a need for improved and harmonized metrics of collecting data about the burden of epilepsy, especially population-based study that stratify estimates by age, sex, gender, income, ethnicity, race, epilepsy type, and syndrome. Better data on premature mortality, and looking at cost in a standardized approach. So thank you for your time.
Thank you very much, Natalie, for the great overview. That's really very elegant and comprehensive. Thank you very much indeed. We have some time for questions, and okay, we will be looking at the questions at chat in case they are there.
If maybe I could add a few points.
Yes, it would be great. Yes, we have time. Please do.
Thank you. So welcome everyone, and you know, certainly we could have spent an entire day speaking about the global burden of epilepsy. We know that the suffering and disability caused by epilepsy is much greater than I demonstrated in my talk. The huge burden is not only on people living with epilepsy, but also on their families and indirectly on the community. The impact may be due to many aspects: the physical, the psychological consequences, the social exclusion faced by people living with epilepsy and their family, the stigma, and so on. So it's quite broad. One of the aspects that I didn't cover in the interest of time, for example, are the comorbidity that really not only, you know, increase the burden in terms of the psychological impact and so on, but also increase the risk of injury, increase the risk of mortality. So for instance, we know that the most prevalent psychiatric comorbidities are depression and anxiety in adults and children, you know, intellectual disability, autism spectrum disorder, ADHD are quite common, and even in children that can even be up to, you know, to 50%, it can be quite high. So those are aspects that I didn't discuss, but really, really important to think, you know, about these and really address them, because they do contribute to the burden of epilepsy considerably. And so just keeping that in mind. I did not address first seizures. I focused on epilepsy, but that's something to think about as well, because, you know, in recent years, the definition of epilepsy has changed. And in some people now who have a single seizure, they may actually meet the definition for epilepsy. So also very important to think about first seizure and their, you know, their incidence and so on, because some of these individuals may in fact have epilepsy. So those were just a few extra point that I wanted to raise. And perhaps my colleagues may have other
we have another question for you. Sam is asking, can you address a bit the confusion about the total number of people with epilepsy in the world?
Very good question. So are you asking Professor Wiebe, you know, what the actual number is and why there's controversy? If is it 50 million, is it 54 million, is it 60 million?
Right.
Right? Okay.
Yes, thank you, Natalie.
Very good. So to tell you is, I do not know the answer. But what I can tell you is it's definitely more than 50 million. It's probably more than 60 million and may even be more than 100 million. And the reason I say that is that there are different estimates that are used. So for example, some of the studies that are done may look at, you know, epilepsy in terms of, you know, as a primary condition and so on, but sometimes some of the cases of individuals with epilepsy may be classified under, if it was due to a stroke, for example, may be classified under cardiovascular disease. If they had a traumatic brain injury, it may be classified under that group. So sometimes some of the global burden work and so on, they may end up not being classified under, you know, epilepsy primarily. These individuals may be under other neurological conditions. So that can under ascertain the estimate. The other issue is under ascertainment because of underreporting and people concealing their diagnosis. So we know, for example, that in many low-income country, but also in high-income, some people will not report that they have seizures or epilepsy because that will prevent them from getting married, having children, they will lose their job and so on. So we know that the burden is much greater for that reason. There are also studies, certain type of data may be problematic in some cases if they are not validated. So sometimes using certain large databases, if you don't have a valid case definition and you confirm that you are capturing everyone with the diagnosis, sometimes you may under ascertain. So for example, using administrative data or electronic medical record, which many of us use to understand important outcomes in epilepsy, it's very important to make sure that the sensitivity is good and that, you know, those that we are capturing have the diagnosis. So I think there are many reasons why it is under ascertained, and I didn't fully answer your question with a number, but what I can tell to the audience is that there is no doubt that the burden is much higher than we report. And so, you know, my suspicion is probably even closer to 60 or 70 million. But unfortunately, without, you know, and there are studies where they do door-to-door survey and they evaluate everyone initially with some screening tool, and then the diagnosis is confirmed with a neurologist and all that. But even in some of those studies, you know, there can still be under ascertainment. So I think we have to do a better job. And regardless if it's 50, 60, 70, or 100 million, there are a lot of people affected by epilepsy. And so it doesn't matter to me if it's 50 or 100 million. It does, because it may influence how many dollars, you know, go towards epilepsy if the burden is higher. So we have to do a better job at capturing it. We have to do a better job at recording it in our health systems, in our notes, in our electronic medical record, and the reporting that we do, you know, through ICD coding, everything, you know, we need to document epilepsy better in our notes as providers as well, so that it gets captured and that we can have more resources for it.
Thank you very much, Natalie, again. Well, do we have questions from the audience in the chat?
There are two.
Okay, so maybe you could, or Nico, if you could just.
Okay.
Okay, okay, yes, now I got them, yep. So there is a question, does the number vary because of the onset due to children growing out of seizures versus the onset in teenage years plus access to treatment?
Yes, so
this is the question from Dr. Floyd.
Deirdre, very welcome, Deirdre. Nice to see that you've joined us. So definitely the number can vary, and it will depend on which estimate you're looking at. If you're looking at point prevalence, you know, and looking at a moment in time, if somebody had it 5 years before and they outgrew it, they're not going to be captured in that number. So if you're looking at, you know, in 2020, how many people have epilepsy, and if a child outgrew it in 2019, they will not be captured. However, if we look at lifetime prevalence, we're looking at the whole lifetime, then it doesn't matter when people had it. They will be captured, you know, ideally regardless of when they had it. So it depends on the estimate, but you're correct. If somebody outgrows it, then they will no longer appear if you're looking at active prevalence. And again, active prevalence can be many things. Some people say if they had a seizure in the last 5 years, in the last year. So all those things matter when we look at those data. And in terms of, you know, developing in teenage years and access to treatment, certainly there are many people who are not diagnosed because they never have access to treatment or to a provider or to healthcare services, or they're misdiagnosed with something else. So that certainly can be an issue as well.
Thank you very much, Natalie. There is another question. Access to highly quality epilepsy care is a huge problem in undeserved areas, even in the US. Waiting period to get access to level 4 center in several months to years for surgical evaluation. I appreciate your comments, thanks. Yeah. And this is, okay, yeah.
Yes, so this is from Hari Prasad Kuni Vidu, and we have, so thank you for asking this question. I will report a conflict of interest because I have spend a lot of time doing research on increasing access to epilepsy surgery. So that is an area that I am very passionate about. Professor Weeb is smiling because he's been involved in some of this work as my mentor. And so it's a very important area, and you are correct that many people wait a long time. Remember that, you know, some issues could be because of a lack of medical insurance, or, you know, they cannot afford to see provider and so on. but there are also misconceptions. You know, there are primary care physician, even neurologists who never refer people who have ongoing seizures, and you know, have misconception about the high risk related to epilepsy surgery, which we know that in people who are carefully, you know, and have a careful evaluation, that the risks are actually not high and the outcomes are very excellent, you know. So so there are many reasons. There are misconceptions among people living with epilepsy. Sometimes I've seen people where they had a family member who had brain surgery and had a very bad outcome. It wasn't related to epilepsy, but this now creates a barrier. So numerous barriers and facilitators to accessing epilepsy surgery. It's a big problem. Too many people are living with drug-resistant epilepsy, and this is increasing their risk of mortality, injury, and poor psychosocial outcomes. So it's something that needs to be addressed, and you know, this requires intervention on multiple levels, at the, you know, education at the patient living with epilepsy and their people living with epilepsy, with the providers, and also in kind of society more broadly, and changes in public health policy and so on.
Thank you very much, Natalie. Nico, I think we have to move on. And once again, Natalie, many thanks indeed. And to tell the truth, I have a couple of questions to you, but hopefully at the end. And it's my great pleasure and honor to introduce, actually, once again, all the speakers in this session doesn't need any introduction because they are so eminent and well known. But I would like to introduce our president of the International League Against Epilepsy, director of the Clinical Research Unit of the Cummings School of Medicine, University of Calgary, Professor Sam Bebe. It's an honor and pleasure to have you here, Sam. So Sam will be presenting the talk on improving epilepsy care and research. You're very welcome.
Greetings, everyone. My task in the next few minutes is to share with you some views on how to improve care and research in epilepsy at a global level. So for this, I will use a series of principles that are really global and refer to more than anything the ILAE perspective, and everything will be addressed in broad strokes from this global perspective and not from one specific example or from one specific area. As you know, the ILAE is an organization that represents 123 countries in the 6 regions of the world, and these regions are depicted in this slide. So what is the approach that I think the International League Against Epilepsy as a global organization follows to some degree, or should follow, or should aim for to some degree, in achieving better care and better research from a global perspective? Well, consider 4 edifices or 4 large pillars as a way to conceptualize this approach. One is education, the other is advocacy, then we have standardization and evaluation. And if you put the first letters of those words together, you have the word ease, which does not necessarily mean that it is easy to accomplish, but it's easier to remember. These 4 edifices are built on a platform or a bedrock of extensive collaborations. And we will, in turn, address each one of these from a conceptual perspective. So from the point of view of education, as you all know, the educational activities of the International League have gradually consolidated into our educational platform, which is the ILAE Academy. I encourage you to visit our website in this regard. It is worth asking then, to address education, who do we educate, what do we offer in terms of education, and how do we provide this education? With regards to who do we educate, well, our target really are a broad range of audiences. We have clinicians, both in primary care and specialists, allied health professionals, researchers in basic and clinical sciences, And very importantly, the next generation of clinicians, of researchers, of care providers, and academicians. So this entails students in the health sciences, really, and in the social sciences as well. What is offered, or what should be offered? Well, increasingly, we aim to offer educational elements or educational activities based on an educational curriculum. And this is very important because it provides a structure and it provides a standard. These elements can be a variety of things, not only courses, but also workshops. It could be lectures, it could be written or other didactic material, but it should be targeted to a specific audience because the setting changes and the setting determines also the needs for education, the type of educational activities that are important. So it should be needs-based material and activities. And importantly, we're increasingly aiming towards examinations and then eventually certification. That's an important component. How we offer these educational aspects is also an important question. Using valid educational methods for adult learning is crucial. Defining achievable, realistic learning objectives that are aligned with an educational curriculum is equally important. Interaction is a critical piece of education for adult learning, and we try to implement this in every modality of teaching, whether it is online, through forums, discussion groups, even email discussion if other means are not possible, or using chats or social media. And then the issue of accessibility is a crucial aspect. As an international or global organization, this is one of the core aspects of our thinking and considerations in providing education. It should be accessible both in terms of cost, but importantly, language. There are increasing efforts to provide translation of our educational efforts. And then finally, it should be multimodal, adaptive, and it should be timely to the needs that are out there in our learning community. So that is education, the first pillar. The second one is advocacy. And the ILAE has created the Global Advocacy Council, which has adapted the motto, Action for Epilepsy. And what this entails really is being there where it matters. And where is that? Well, these are the places that we try to be to advocate for epilepsy care and research at international and regional agencies, with governments at various levels, funding agencies and funding bodies, philanthropists, educational institutions. We would like to increase our ability to partner with universities and other educational organizations. And then importantly, emergency response organizations, and this has become really paramount with the current pandemic situation, where we need to make sure that emergency responses include services for epilepsy and that those are not neglected. We need to be there when it matters. And this is also crucially important. It is important to realize that when entails persistence. One time is not enough. We need to be opportunistic. We need to use the opportunity as it arises. We need to be there on time to take advantage of the opportunities that emerge and be responsive to the need that arise. So be nimble, agile, responsive, timely. Those are all important elements, not only of advocacy, but in particular of advocacy. And then finally, it means also being there in the manner or the way it matters. So how? With the right message, with the right to the right audience, addressing a relevant issue or point, being collaborative with other efforts, and being invested, and providing resources that may be necessary in order to reach that target of advocacy that otherwise would not be possible. So advocacy, the second pillar, is an extremely important area. The third pillar or edifice is standardization. The ILAE is seen worldwide as an authoritative source of information and standards. And it is important that we increasingly provide this guidance that is needed by our international community. It really is about pointing the way. And how do we do this? Through the assembly of official definitions for clinical purposes, for technical purposes in epilepsy, through classification systems, as we all know, through the assembly of practice guidelines and recommendations for practice, through expert consensus achieved through formal means of consensus gathering activities, and then through providing certification of specific clinical activities or specific educational activities. And this is an increasing area of focus in the ILAE. So standardization is an important way of achieving better care and better research in epilepsy worldwide. Importantly, for example, in research, there were publications recently in epilepsy by our basic research community in terms of preclinical research methodology standards, and these are still being produced and increasing, just as an example. And then the fourth pillar is evaluation. So every activity to be improved and to be effective needs to be evaluated. The activities that we engage in to improve care and research should really have at its core, at the beginning, evaluation in mind. There are many ways of evaluating activities and projects, and one possibility is the 5 A's of evaluation that are applied in many other areas, including, for example, evidence-based medicine, where we have epilepsy at the core. And we ask which activity or which area is to be evaluated. What is the question or the outcome of interest? We then acquire the information that is necessary in order to exercise the evaluation. And then we appraise the information, we assess it, we evaluate it, we apply the information gleaned to the problem at hand, and then we act on it so that in a recursive manner, we ask the next question, and in that manner, the end of the evaluation becomes the beginning of the next evaluative process. Now, this should be lean, feasible, and meaningful. Methods should be valid. It should be recursive with every major juncture or initiative, and it should become part of the culture of our activities. However, it is easier said than done. It is not easy to implement, and it is even more difficult to maintain it as part of our ongoing culture. But evaluation is a necessary process to improve care and research. And then, as I mentioned earlier, recapitulating the 4 pillars of education, advocacy, standardization, and evaluation rest on a bedrock of solid collaboration. And collaboration should be open and inclusive. It should be adapted to the needs and the settings that are at hand. And it should importantly accommodate different values and preferences. As a global organization, this is an extremely important principle. Ideas come in very different shapes and colors, and we should be able to make use of our collective efforts to improve research and care. As I mentioned before, the words agility, ability to adapt, nimbleness are important and are particularly important in collaboration, being open to new ideas, organizations, and investments. And then keeping the bar high. Collaborating does not necessarily mean lowering standards, but rather having flexible but high standards, remaining highly ethical and transparent in our activities. This is a bedrock for implementing the edifice of the 4 pillars. And with that, I would like to thank you with a thought that at the end of the day, our core values determine our activity.
Thank you very much, Sam. Great talk and, well, really strategic. Thank you very much again. We got several questions and some of the questions you have already addressed. And there is another question, and we promote the ILA statement always. It always creates interesting debate, and through it could be addressed virtually to help get everyone on the same page. So, well, would you comment on that?
I think yes, Ella, thank you very much. I think this is referring to the previous question of, is this a disease or epilepsy a disease or a disorder? I answered that online. So I think that has been dealt with, and perhaps we could move on if there are other questions, either from the audience or the panelists.
Well, if I might continue, and thank you for answering via chat rapidly. Well, I think we are now facing immense challenges because of COVID, and we have to modify dramatically care and research. And you all arranged, and there was an excellent seminar for epilepsy and COVID. But would you comment just to know what are the challenges now, and what are the key answers to that, in your opinion?
For sure, that's a very big question, a good question and a very big question, Alla. As you know, I would like to just mention something briefly before this. I know that the talk I gave is very broad and global and strategic, and that does not address one specific area or element or region or country or group of people. So, but that was a global perspective. So I just want to open the door if there are people who have questions that are a bit more focused or directed. I think that we as a group of panelists can probably address that. But going back to your question, Alla, the pandemic is posing tremendous challenges at many levels. And yesterday during the opening ceremony, I mentioned briefly what the ILAE is doing in terms of addressing this. We have a task force on COVID that was created rapidly and that is reacting very rapidly to developments in COVID. It is led by our elected president, Helen Cross, and it has representation from all over the world. We're addressing aspects of telehealth and telemedicine, psychosocial burden or stress or distress on patients, ability to provide care, access to care, and also aspects of research. So we have three big components there, which are care providers or clinicians, patients, and then researchers. And all of these areas have been affected. We have produced a number of publications in Epigraph, and we're putting together something to come up in Epilepsy or Epilepsy Open about aspects of research and how this is impacting our research, our ability to see patients directly and to engage patients in research and what modalities are being offered. So this is at the grassroots level, how it's affecting us. But I think a very important point in line with my presentation and at a more global perspective is the issue of quality of research. I think everyone has such an urgent need for information that all information is put out there. And we are now facing a situation of what I call infodemics. And it's not my word, it's a word of the WHO actually. And it's an overabundant, it's an epidemic of information that runs rampant. And it affects individuals, organizations, and everyone. And then people don't know what is true and what is not true anymore. They don't know what information to trust or not to trust. And there are some principles that the WHO is established, and we are trying to adapt to that. But the bottom line is that, as I said in my last, close to my last slide, we should not lower our standards. This is a risk. I mean, just look at the retracted publications in key journals like Lancet or New England Journal of Medicine by large research groups, because the research tends to be flawed and it is not valid, it is not believable. So I think we should be very careful to balance the urgent need for publication and information with having rigorous standards that are still adhered to, as desperate as we are for information. I think that this will go a long ways towards providing valid information and not confusing people, and what is worse, not misleading people, professionals, researchers, and patients as well.
Thank you very much, Sam. Would other members of the panel ask some questions?
You know, I just saw a question. Sorry, I just saw a question, if you don't mind, Ella, from the Q&A. And it says, would you
Yep.
explain the vision of the ILE in terms
Yes.
of teleeducation? And I would very happily do that. I think that both Natalie and I can speak to that because we are engaged in that. I'll just start by saying that prior to the pandemic, we created a task force on telehealth or teleeducation. And again, Helen Cross, Roberto Caraballo are strongly involved in that. And there are tons of people around the world that have a lot of experience with teleeducation. The pandemic has brought this to the forefront. And we are putting together a number of aspects. First, survey and teleeducation, that is still ongoing. And secondly, some elements that are critical to incorporate in any teleeducation encounter with a patient. I don't know, would you mind, Al, if I ask Natalie to comment on that, because she's directly involved with Helen Cross in.
Please do. Natalie?
Thank you. And so you're referring to more teleeducation in terms of, you know, how do we educate providers about how best to do provide telemedicine and so on, right?
I think that, let's see, what is the question exactly? ILE in terms of teleeducation, correct?
So I'm not sure if it's teletraining, but I think it is teleeducation. So telemedicine as really, you know, the utilization of telemedicine has increased exponentially since the pandemic, as was mentioned by Sam, and it's something that is not going to go away. So we need to become better at providing telemedicine. There are numerous issues related to telemedicine that, you know, numerous barriers and facilitators. One of the issue that we've been dealing with is just in terms of, you know, what are the important elements that need to be addressed when you are doing a telehealth visit with a person living with epilepsy. So we've been working with Professor Cross and others on the COVID-19 ILE task force to provide some recommendations, as well as the telemedicine task force as well that Professor we mentioned, developing some elements, you know, of the history taking and so on that, you know, that are recommended for a telemedicine visit. And of course, you have the issues related to the seizure history and epilepsy history and so on, but also other aspects that people are especially dealing with right now, making sure that they don't have any COVID-related symptoms, because that could affect their seizure frequency. They may be started on COVID-related medicine that could interact with their anti-seizure medicine, so important to address that as well, but also the psychosocial aspect and whether they're getting support and they're able to get their medication and so on. So that's one aspect, is just about teleeducation in terms of how do you, you know, what type of information do you ascertain from a telemedicine visit? But then there are many other aspects that need to be addressed in terms of how do you do a telemedicine physical exam? You know, what are the components you can evaluate and how do you enhance that? How do you increase access to telemedicine for those who may not have access? You know, what are the different platforms that can be used and so on? And a lot of that relates to enhancing public policy to try to make it easier in every country for telemedicine to be done.
So Ella, could I just follow up? You know, I misread the question a little bit. I'm sorry. You know, the question is about teleeducation, and then I started talking about telehealth, and I asked Natalie to talk about telehealth. But teleeducation, I think it's Dr. Nguyen that asked that.
Yes.
You know, teleeducation or virtual education is the centerpiece of the efforts in education in the ILE. And we believe that this is here to stay. This is not just a fad. We're discovering excellent ways of educating people. And the key now is to begin to incorporate that with actual clinical practice, because you can educate in a classroom to a certain degree and people can interact and they can learn from one another. But then there comes a time when you need to actually learn with actual clinical practice, and we're looking at how to begin to incorporate that in level 2 and level 3 of the ILE curriculum, as you mentioned. Yeah.
Thank you very much, Sam, and thank you very much, Natalie. We are moving forward, and it's my pleasure to give the floor to Nico Moshe.
Thank you, Ala. And it's with great pleasure that I would like to introduce Mary Secco, who is the Secretary General of IBE, the International Bureau for Epilepsy, and I will describe her as one of the most passionate people in advocacy that I know of.
Thank you.
For the sake of time, Mary, let's take it. And after you finish your presentation, please expand your definition of what care should be. Go ahead.
My topic is improving the social condition of people with epilepsy. My name is Mary Secco. I'm Secretary General of the IBE. And for the past 2 decades, I have worked at Epilepsy Southwestern Ontario, a community-based not-for-profit that supports people living with epilepsy across the lifespan. Working on the front lines, too often I find myself providing information and support services during a crisis. After the loss of a job, a relationship, or a driver's license, or after an embarrassing seizure at school, or when seizures become drug refractory and people feel hopeless. In the next 10 minutes, I will provide an overview of why social outcomes matter and ways we can proactively deliver programs to improve the social condition of people with epilepsy before they find themselves in crisis. I have no commercial disclosures. Longitudinal data tells us that seizure remission does not ensure good adult social outcome. It tells us that children with epilepsy are more likely to have higher rates of incomplete education and unplanned pregnancy. It tells us that children with epilepsy are more likely to live in poverty and to be socially isolated as adults, and are at higher risk of having psychiatric or social problems. Researchers tell us that 50% of mothers of children with epilepsy are at risk of clinical depression, and this increases to 58% for anxiety. In Canada and the USA, 1 of every 2 adults with epilepsy is currently unemployed, and these were pre-COVID stats. The role of community-based epilepsy agencies is to alter this negative trajectory. When asked to identify the barriers for people with epilepsy, IBE and ILAE chapters from every region in the world provided this ranking. 126 chapters identified persons with epilepsy face barriers in finding jobs. Our chapters identified restrictions at school, barriers in marriage, social isolation, and discrimination. These barriers are indications of social exclusion for people with epilepsy and their family. To improve the social condition of persons with epilepsy, we need to understand that the seizures are the tip of the iceberg. It is well understood that persons with epilepsy need a proper diagnosis and a treatment plan. They need access to safe and affordable medicines, diet therapies, and surgery. But people with epilepsy also need quality social care to address the cognitive, psychological, and social consequences of this disorder. Despite strong research evidence that the impact of epilepsy goes far beyond the medical management of the seizures, we still see health policy and healthcare providers ignoring the non-seizure needs of persons living with epilepsy. So to improve social condition of people with epilepsy, we need to address the challenges below the surface. We need to address the comorbidities. We need to address memory, learning disabilities, ADHD, depression, anxiety, social isolation, stigma, and fear. Multiple studies indicate that it is these comorbidities that are prevalent in childhood epilepsy that place a greater negative impact on health-related quality of life than do epilepsy-specific factors. Simply stated, when these comorbidities go untreated and unrecognized, we leave children with epilepsy and their parents with significant unmet mental health needs. Other modifiable factors beyond treating the comorbidities include improving epilepsy knowledge, reducing family stress, alleviating felt and enacted stigma, and changing legislation. Improving epilepsy knowledge is critical as low health literacy is associated with poor health outcomes and higher use of healthcare services. People with epilepsy who lack information are more likely to impose unnecessary restrictions on their daily life and to develop negative attitudes and reduced expectations. They are also more likely to hide the condition from others. Low health literacy can lead to adverse health outcomes, including more frequent, clinically unnecessary, and costly emergency visits to the hospital and non-adherence to drug protocols. This STEP model comes from the 2019 WHO Global Report. The model identifies the components of quality care. In all three levels, there is recognition that we need to treat the comorbidities. In all three levels, there is recognition that to improve the quality of care for persons with epilepsy, we need to incorporate social and education services. Frustrated by meeting persons with epilepsy in crisis, Epilepsy Southwestern Ontario and the clinical team at London Health Sciences Centre co-developed a health linkage program we call Clinic to Community. The concept of the program is simple. When a newly diagnosed person is seen in clinic, a referral is sent to us in the community requesting an individualized education session with a trained epilepsy educator. On average, a first meeting with a family takes about 75 minutes, but in that time, the community organization can provide the person with epilepsy with an overview of epilepsy, seizure first aid, and risk management, including SUDEP and depression screening. We can also provide guidance on many topics, including epilepsy and birth control, school and workplace legislation, and how to stay safe in bed at night. The benefits of this referral program is that it's easy on the healthcare provider because they simply have to send a fax. And it's a preferred format for the family who can receive the education in the community at a time and location of their choice. The biggest benefit of a program like this is that coordinated care has been determined to be one way to improve the social condition of people with epilepsy. Coordinated care that extends beyond the clinical setting provides families with the knowledge and tools to become confident and manage the epilepsy. It leads to disclosure and acceptance of the condition, and it reduces family stress. When you give people with epilepsy disease-specific knowledge, they give back by becoming advocates. They educate others, engage in research, and raise important funds for epilepsy. These two landmark reports identify the importance and priority of eliminating stigma in epilepsy. Stigma leads to social isolation, delays in seeking treatment and care, reduced educational attainment, unemployment, poverty, poor mental, and poor physical health. The good news, though, is that social support, epilepsy knowledge, and coordinated care have all been found to reduce stigma. School support programs have also been found to improve the social condition of people with epilepsy. And this actually makes a lot of sense because children with epilepsy have higher rates of school absenteeism to recover from seizures, attend medical appointments, and to establish new treatments. But they also need to cope with social factors, including embarrassment, teasing, and bullying after seizure at school. This is compounded by the fact that some parents and some teachers overprotect the child by placing unnecessary restrictions. So one strategy to improve the social condition of children with epilepsy is to provide school support. This school support is a universal tool that can be used anywhere in the world to teach skills like seizure first aid, to dispel myths, and to improve understanding and acceptance. Another universal tool that can be used to improve the social condition of people with epilepsy is changing legislation. For example, Policy Memorandum Number 161 is a law to promote the safety and well-being for students with epilepsy. This law states that every student with epilepsy must be provided with a plan of care. When children have a plan of care at school and parents have open communication with their school system, this improves outcomes for children with epilepsy. We need legislation to change and to challenge punitive laws, including lifelong driving bans in the Caribbean region and discriminatory workplace legislation in many parts of the world. The public health strategies that I've identified in this short talk are global. We can identify and treat the comorbidities. We need to improve epilepsy knowledge. We need to provide school and workplace support. We need to address family stress, and we need to reduce stigma. Implementing programs to coordinate care between the clinic and the community gives persons with epilepsy the knowledge to understand the diagnosis and the confidence to feel that they can cope and manage their condition. This is my final slide. I met this couple last summer when I was in Cambodia, and they sustain their family by selling fish. So I honestly think I chose this photo because I miss travel so much, but also because it reminds me of the proverb, give a man a fish and you feed him for a day. Teach him how to fish and you feed him for a lifetime. It really is the same in epilepsy, but the fish in our case should be health and social care in combination, because these are the tools that our families need to manage their condition, not for one day, but for a lifetime. Thank you.
Thank you very much, Mary, for the excellent talk. Would you like to address some other points as we have some time?
I would actually, thank you. So I think about this whole concept of care. And in the community, we measure care differently, actually. We measure care on social outcomes. So is the person able to live with independence? Are they able to participate fully at school? Are they eligible and able to continue to work? And unfortunately, we kind of have a failing grade in that right now. If you think of Canadians and Americans as adults living with epilepsy, 1 out of 2 doesn't have a job. And one of the most important indicators of belonging and social acceptance is being able to sustain yourself and not live in poverty. So I guess my question is really to maybe be a bit provocative, but if we expanded the concept of healthcare to include social care and coordinated care, I really believe that people with epilepsy would benefit. And I'm going to give some real examples of where we have to go. So if you Google right now, epilepsy and surgery, you'll get over 1 million publications. If you Google epilepsy and health literacy, you'll get 23,000. If you Google epilepsy and self-management, you'll get 75,000. If you Google epilepsy and drugs, you'll get 1 million to 300,000 plus. So I guess from the community side, we always we'd like to know what's the best way to work with clinicians, in particular clinicians that run epilepsy monitoring units and are fueling all of this research, to have them include social care as one of the indicators that they look for in improving the quality of care that's given to people with epilepsy. So it's, Sam, a new idea. So that's my question.
Thank you very much, Mary. We are getting many questions, and many thanks to the audience. By the way, we have 136 participants, and that's great. So Mary, there are 2 questions for you. And do you see them, or I should read?
I haven't been watching, sorry.
Okay, in my area, it has been difficult to establish that rapport with the clinicians, so they will refer their parents to our agency. The issue we encounter is patient confidentiality. How did your agency get the clinicians on board to support this program? This is the question from Dr. Floyd.
Okay. So I think that has 2 very important answers. The first one is credibility of the services we provided. So Epilepsy Southwestern Ontario has been working in partnership with the clinicians in our service area for a long time. And we have been involving their feedback in the type of evidence-based programs that we provide. So there's this relationship of trust. They know that if they send us a referral, we will provide evidence-based, authoritative, and appropriate information to that person with epilepsy. And that's the first thing. So I call on community epilepsy agencies to say, we need to get our act together. A clinician will refer to us and use this kind of mechanism that we have in Southwestern Ontario if we do our job well. So part of that is that we're invited to rounds at both our children and our adult hospital to learn. We have advisors on our board that teach us, so that there's this comfort level that what we're sharing with the person with epilepsy is information that they want shared. We also wrote the Clinic to Community program in partnership with these doctors. So we looked at the guidelines in the patient education checklist for the province of Ontario, and we addressed each and every one of those, each and every one of the things in the checklist in our program. Then we got the program approved. So that made this a shared program. So the other reality is, if you work with people and it's there, and it is shared, you'll see a lot better response. So I am very proud to say that this program at this point has had 1,100 referrals for community-based support. And it's not only from London Health Sciences Centre. They're coming from community neurologists, they're coming from community family doctors, they're coming from social workers, they're coming from nurses. So when you get a program that starts to make that linkage, that coordinates care, you start to see it grow in really significant ways. So my answer again is, we need to be credible, we need to do our job well as community organizations, and we need to earn the right to have this relationship with our clinicians' patients.
Thank you, Mary. There is another question. Do you have suggestions on how community epilepsy agencies can ensure that healthcare practitioners see the value of referring their patients?
Yes, the biggest challenge we have is and it goes back to my answer for the first question, we have different levels of care being provided in different communities. And that's because we're not funded under any Ministry of Health envelope. And once we get funding like that, then we can be true partners in this coordinated care. I kind of spoke there and didn't really focus on that question, but the challenge we have right now is that we have these beautiful systems of epilepsy monitoring units where people are going in for surgical evaluation, but we're seeing a different kind of person living in the community, a person who has this chronic epilepsy. They might be acute at some point, but too often they're very chronic, and they're living with really poor outlooks on life. So I guess if we want to see this kind of synergy work better, maybe we have to look more at those public health principles of chronic disease management, coordinated care, shared decision-making, health literacy, and that would help us immeasurably, I think, to see improvements in care for people with epilepsy. I'm not sure I answered that question appropriately, though.
Thank you, you will.
Yeah, I think maybe you should ask one of the clinicians, what would it take for them to be a partner in coordinated care? Because you're the target. All of our organizations want to work with the doctors. They want to be there. So what would it take to do these programs?
Well, I think Sam would start, and you have, Sam, a number of other questions, so I would just give the floor to you.
So Mary, I think that you answered it. I think that the issue really is the huge variability we have in terms of supporting agencies. It goes from nothing to a very bare bones functioning group to a highly developed group, right? So you cannot apply the same standards to everyone. I mean, if you have access to a high functioning, well organized, multi-service agency, like the examples you gave, Mary, then by all means, please make use of those resources, right? The problem is that probably is a minority, Mary. It's my guess. I don't have numbers, but my guess is that is the minority. The minority of people really have access to that level of support.
Agreed.
Thank you, Sam. So there are other questions for you. I think you are monitoring the questions also. So the question from Bill Teodora and
Sure.
another, Would you answer, please?
Yeah, Bill Theodore asked whether patients with epilepsy are turning to alternative medicine in times of pandemic, just like they're turning to alternative medicine in other areas of care. And, you know, I think that any one of us could give comments on this, because I don't think that there is any evidence in this regard, or any solid evidence. I've been kind of monitoring surveys and monitoring output in this regard. But what I can say from an anecdotal and personal experience perspective is that yes, absolutely. I mean, people in our experience, for example, I have at least 2 patients that are postponing already to go epilepsy surgery because they first want to try alternative medicine because of many reasons. They don't want to come into the hospital. They don't want to be exposed to the health care system. They're trying things, and they have terrible epilepsy. They have very severe epilepsy, very dangerous epilepsy. And then if you talk to colleagues around the world where alternative medicine is a more constant way of patients treating their epilepsy, absolutely yes. And in some instances in a very unsafe manner, because it's all word of mouth. Try this, it helps both protect you from COVID and it helps the seizures, and you know, don't take this, take that. And then the third one is access, because access is so limited in many places, you know, continued access to medication even, that patients are forced with a need to implement more alternative or complementary medicine, which is all right if it's safe, and if it's all right if it's something that helps, but in the majority of cases, it is unproven treatments. Like in the examples I provided, for example, the treatment that is being pursued is spiritual healing and you know, shamanic practices. We're concerned about that. So that was one question from Bill. I don't know if anyone has any comments about this. You know, clinicians, Natalie, Alan, Nico.
Well, there is a survey ongoing and study ongoing, so we will see what's the attitude to the alternative medicine, and well, whether it was changed over times.
Correct.
So I don't have any evidence about holistic, but we are doing some research with Kathy Speechley's team on the impact of mindfulness for parents and children with epilepsy. So can we reduce stress? And will the reduction of stress reduce seizures in these children and improve outcomes? So I think there's a lot of other ways to look at how we can really do good research in non-pharmacological, non-surgical ways to see if we can improve the outcomes for these families. And when I say families, I mean across the lifespan. I just always say families, but a family is an adult in his care and his or her care partner. It's across the lifespan that we could be looking at maybe stress reduction and seeing if we could be looking at some of those strategies.
Thank you.
Sorry.
Natalie, you would like to comment on that?
I think there are other questions, and I know we're almost out of time, so we can move on if you would like.
Absolutely. So I think you answered your question, Natalie, already. So there's another question to Sam.
Yep, I think there's 2 related questions. One relates to cell phone use. The other one relates to use of Sunrise Clinical Manager or Epic or whatever health record system. Can this be used to improve patient care? And I think that this all comes to 2 issues. One is the use of telehealth, which is increasing. There is another initiative in the ILE, which is looking at creating a platform where patients can possibly upload their videos taken at home with a cell phone in a safe manner. I know that Samir Zuberi in the UK is leading this effort and being very successful. I mean, the uptake of this platform in their hands was huge immediately. So I think that this would be a very, very helpful thing. But even if you don't have that platform and you have a way of using a patient-taken videos and cell phone and reminders and all of that, would be terrific. The issue, of course, is privacy and security. And that has to be dealt with. And I know that healthcare systems are overwhelmed with dealing with COVID right now, but it will be an essential component going forward that healthcare systems or that health organizations can provide secure system, private system where patients can do that or assist with that in some manner. The second one, and that addresses also Epic or medical record management, which has a patient portal, and there can be communication, and they can access information, and they can access care and prescriptions and all of that. So I think that the answer is yes. But the second one is closely related to what Mary said earlier, which is empowerment and self-management. I think that the pandemic has brought to the forefront the tremendous importance of patients knowing their condition, taking care, taking control of their management of their condition, knowing their medication, knowing their triggers, knowing their health factors that are important, keeping track of their episodes, communicating adequately. I mean, I cannot overemphasize how important this is in times where you don't see people face to face, and they cannot just run and see the family doctor immediately. So self-management and patient empowerment are critical aspects, I think, in the world we live in. And I think that this is a lesson that we have been kind of ignoring, Mary, as you correctly said. If you do a search, it's like oh yeah, empowerment, whatever, but I think that this is important, and it should remain. I mean, it can only improve patient care, and that involves use of electronic media, but also use of patient education and so forth.
Thank you very much. I think it's time to conclude, and I would like to thank the organizers, and that's the first Congress, and congratulations indeed. And many thanks to the speakers for the outstanding talks, and many thanks to my eminent co-chair, Nico Moshe. And maybe Nico, you would say something at the conclusion.
So yes, I will echo exactly what you said. This is a wonderful section. It was wonderful to hear all these things and what the LAE and the IBE are trying to move forward in a new world. Just remember that a lot of people are going to be wearing masks in the years to come, in the months to come, which limits communication tremendously. We don't see the mouth, we miss a lot from the people, what they're trying to say. So
Agreed.
This type of communication will be very good. The other concerns that we may have is financial issues related with televisits, telemedicine, uploading information, which vary from country to country. But the LAE and the IBE, I'm sure they will address that. And with that, I'd like to thank you all for pushing forward in a world that we do not know to take care of the people with epilepsy. Thank you.
Thank you.
Thank you. Bye.
Thanks for the opportunity. Thank you.
Thank you so much.
Bye.